Well, thank you guys for inviting me this morning to the symposium and giving me an opportunity to talk about a group of conditions we don't often think about, but are probably a bit more common than we know. And you know, these autoinflammatory syndromes are really an up-and-coming field in medicine in general, and it's giving us some unique insight into the function of the immune system and how disordered regulation of the immune system actually contributes to more common public health issues. So the talk that my title this morning is autoinflammatory syndromes, all who fever are not infected. So it's just something to keep in the back of your mind whenever you're seeing patients with recurrent fevers. So first of all, we'll get the disclosures out of the way, and there are none. Our objectives this morning, I'd like to review with you guys the pathophysiology underlying the autoinflammatory syndromes. I'd like to also go over the signs and symptoms of common autoinflammatory conditions. And then finally, we will review the treatment options and why those make sense immunologically for patients who have these conditions. So what are the autoinflammatory syndromes? These are a group of conditions that are characterized by recurrent attacks of systemic inflammation. When you look at these patients and you do their lab work, they really have no evidence of an autoantigen exposure like you would see in a typical autoimmune disease. That's why we use this term autoinflammatory. This is not an autoimmune phenomenon. So these aren't autoreactive T cells like one might see in lupus, which is attacking the renal tissue and causing nephritis. We don't see any evidence of autoantibodies like we might see in lupus or a condition like Wegener's granulomatosis. And these are all genetically mediated. There is a single mutation that is responsible for all of these conditions. That single mutation results in some dysregulation of the inflammatory response. In order to understand the autoinflammatory syndromes, we have to go back to our basic immunology days, and we have to think about that innate immune system. And the innate immune system is evolutionarily conserved across species. It is composed of what we would consider the first responders. So if there is some kind of insult or attack, these are the cells and the components of the immune system that respond first. The cells we all know of, the neutrophils, our antigen-presenting cells like macrophages and dendritic cells and K cells. Those pro-inflammatory cytokines they would serve as the 911 system, if you will. And interleukin 1, interleukin 6, TNF alpha are expressed to go out into the periphery and signal danger. And then finally the complement system, and those these proteins have the ability to tag foreign proteins and identify them as not belonging and signal a response. The final common pathway for the innate immune system in most cases is activation of what's called the inflammasome. And this is a figure that we're going to come back to throughout the talk. But right now, where I'm going to ask you to focus your attention is on this area here. So this active caspase-1 complex is really what we refer to as the inflammasome, and it can be composed of multiple different protein subunits to drive to the same complex. And the role of this caspase-1 is to convert pro-interleukin 1 to active interleukin 1. So the inflammasome drives production of interleukin 1, and that's one of our pro-inflammatory cytokines. This is a very important item to understand when we're talking about the pathophysiology of the autoinflammatory syndromes. The autoinflammatory syndromes is a very broad term. It encompasses many different types of conditions. And a secondary grouping of these conditions is the hereditary fever syndromes. Now, these really serve as the model for autoinflammatory syndromes in general. They are similar in that they have clinical manifestations that consist of recurrent attacks of fever, serositis, and rashes, and that's fairly consistent across the group of the hereditary fever syndromes. Not surprisingly, given the name, there are often family members who have similar symptoms. So the conditions that are encompassed by this hereditary fever syndrome grouping are the classic fever syndromes: familial Mediterranean fever, hyperimmunoglobulin D syndrome, the tumor necrosis factor receptor associated periodic syndrome, and then the cryopyrin associated periodic syndromes. We're going to go through each one of these individually today at a very high level. Probably each of these could be a talk in and of themselves. But again, my goal is to just have you become familiar with these conditions on a basic level. So FMF, familial Mediterranean fever, it's thought to be the most common fever syndrome worldwide. There are probably thousands of patients in the U.S. that have FMF, and there's in Europe there are countries that have tens of thousands of patients with FMF. The onset of symptoms is fairly early in life. So by the first decade, 80% of patients have had their first attack. By the second decade, 90% of patients have had their first attack. So this is a condition that we can see the onset in childhood. Most of those patients are male, and again, most of those patients have an affected first-degree relative. FMF has a predilection for certain ethnic groups, and those can be Sephardic Jews, non-Ashkenazi Jews, patients of Turks, Arab descent, or Armenians. And there is thought to have been some evolutionary advantage to, as the carrier rates for FMF are extremely high in some populations. And this figure on the right here is actually a map that was put together by two experts in FMF in a very nice paper from 2009 that explored the founder effects of the gene and really tracked the gene as it spread from the Mediterranean area into Western Europe, into the U.S., into portions of South America. And the yellow line that runs horizontally is actually the Silk Road. And for people who remember Béchets and this thing, you know that there's a higher incidence of Béchets and along the Silk Road. It's interesting that you can track that there's a population in Japan that also has FMF, and that's thought to be related to that Silk Road. The genetics behind FMF are actually fairly simple, and they were worked out in the 90s. The gene, appropriately named the Mediterranean fever gene, is located on chromosome 16. This gene is transmitted in an autosomal recessive pattern, and it encodes a protein that's called pyrin. And pyrin is important for control of inflammation, and it actually serves to dampen the inflammatory response. And you can see a majority of the mutations occur in this B30.2 region here. So again, if we go back to our figure from before, pyrin actually combines with another regulatory molecule called ASC. And normally, pyrin would prevent the formation of an active inflammasome, but in this case, the action of pyrin is diminished, and it actually causes a dysregulation of that inflammasome formation, and we get production of IL-1. So what happens when we get all this high IL-1 level in FMF patients? Well, they get fevers. Almost universally, they have fevers. And then abdominal complaints are very, very common. 95% will have abdominal pain. Sterile peritonitis is a common manifestation as well. A large number of these patients can actually have abdominal surgery. You know, they'll have appendectomies, or you know, they'll have an exploratory laparotomy because they think they might have some kind of intussusception. Arthritis is a common manifestation, usually a large joint arthritis in the lower extremities. Erysipeloid erythema can occur in around a third of the patients, and then pleuritis is also seen frequently. So this is a figure that we're going to go over in several other conditions, so I'm going to spend a little bit of time to orient you. The figure on the left is actually a graph of a patient's symptoms, and the bottom is a timeline that tracks the frequency and the duration of their symptoms over the course of a year. So on our y-axis, we have body temperature. On our x-axis, we have days and duration. And so you can see with this patient who has FMF that the onset of the symptoms is fairly abrupt on day 1. And there's a significant rise in the temperature, and then there's a drop fairly abruptly. So the overall duration of the attack is about 36 hours. That's classic for FMF. FMF, the attacks last less than 72 hours. In this patient, you can see the associated symptoms are serositis, vomiting, arthritis, and an erysipelas lesions. This is actually a patient that we take care of, a young man who's probably 18 now, and I think you can appreciate the erythema that affects his left foot here, and tracks up and fades into his lower leg. And this is this erysipeloid erythema that we might see in patients. What we get concerned about in FMF, and if you remember from medical school, is amyloidosis, and it's the major cause of morbidity and mortality in patients who have FMF. So untreated, the incidence is anywhere from 30 to 60% of patients will develop amyloidosis. The figures on the right are Congo red stains demonstrating apple green birefringence of the amyloid material that's been deposited in a glomerulus here, and then this is a hepatic parenchyma here. How do we treat these patients? They all get colchicine. It's pretty easy. Colchicine has been around since the 1920s to treat gout and has really been proven to be effective in FMF starting in the early 1970s by an investigator named Goldfinger. The response rate to colchicine is very good. About 90 to 95% of patients will have a positive response to colchicine. We can see a complete control of symptoms in up to 2/3 of patients. And there can be a reduced severity in about 20 to 25% of patients. 5 to 10% of patients fail colchicine. Now, when you talk to physicians who take care of large numbers of FMF patients, we're talking hundreds of patients, they feel that the only reason why people might fail colchicine is they fail to take it. And the failure to take it can also be driven by the side effects of colchicine, the most problematic of which is diarrhea. And so some patients are just intolerant to colchicine. They can develop diarrhea, so they stop taking it. Most importantly, colchicine reduces the risk of amyloidosis to almost zero if patients are compliant with it. For those patients who either have a partial response or cannot tolerate colchicine, we will use IL-1 antagonists, so medications that block the effects of IL-1, and we have 3 of those to choose from today. So that's FMF. Now we're going to talk about hyperimmunoglobulin D syndrome, or HIDS. The onset of HIDS is actually much earlier in life than FMF. Average age of symptom onset is within the first 6 months, and 70% have had their first attack by 12 months of age. So this is something that we see onset in early childhood. One of the almost pathognomonic historical findings is that the parents will say when this child gets his or her vaccines, they have a terrible fever attack. It's not the typical he's feverish for 24 hours and a little fussy and achy. This is a sustained fever of usually 101, 102 or greater with rash that persists for about 4 to 5 days. And it happens every time they get their vaccinations. The genetic mutation behind HIDS actually occurs in the mevalonate kinase gene. So again, if we go back to the medical school days and we think about the cholesterol biosynthesis pathway, there is the mevalonate kinase comes just after the HMG-CoA reductase step, and there's a loss of function in the mevalonate kinase gene. Now, it's not a complete loss of function. It's a partial loss of function. It goes down to about 5% of normal. And for those of you who really paid attention in your genetics and in medical school, there is a condition called mevalonic aciduria, which is an inborn error of metabolism, where you completely lose the synthesis function of mevalonate kinase. And those patients have failure to thrive, they have developmental delay, they have other physical stigmata that go along with it, but they also have fevers. just recently, for a long time, nobody could figure out why this problem in the cholesterol biosynthesis pathway would actually result in fevers. But just recently, they have shown that a byproduct called guaranyl-guaranopyrophosphate actually serves to directly stimulate inflammasome and cause IL-1 production. So how do these patients look clinically? Again, they're going to have fever. We know that. The duration of the fever is longer than FMF. Again, this is usually 4 days, 5 days on average. The mean frequency of the fever is around every 4 weeks, but if we go down to our timeline here, our calendar on the bottom, we can see that the interval of time between attacks is actually, it's variable. It's not fixed. And that's a key historical finding here as well for a condition we're going to talk about later. But most of these hereditary fever syndromes, the interval of time between attacks is variable. It's not fixed. So we'll use this term, a lot of people will use the term periodic fever interchangeably with hereditary fever syndromes, and that's really not the case. When we talk about periodic fevers, we're talking about fevers that have a fixed periodicity. The amount of time between the fevers is fixed. Hereditary fevers, it's variable. And so those drive different differentials when you use that terminology. So we should be cognizant of that as we move forward. A lot of patients with hyper-IgD syndrome will have cervical lymphadenopathy. This differentiates them also from familial Mediterranean fever patients. Again, a lot of these patients have rash, and you can see that readily here. Abdominal pain, again, frequent, just like in FMF. Arthritis as well. Headaches are fairly common in HIDs, and that can serve to differentiate them from FMF. Treatment. Non-steroidals and steroids can be effective. Initially, when we discovered this genetic abnormality in the cholesterol biosynthesis pathway, we thought, okay, well, we got these HMG-CoA reductase inhibitors. Let's try one of those and see what happens in these patients. And actually did reduce the number of febrile days, but it had no effect on the attack rate. And that, again, this is in contrast to a drug like colchicine, which really reduces the number of attacks and certainly the severity of attacks in FMF patients. Drugs like etanercept, which block TNF-alpha, and anakinra, which block the effects of IL-1, have been shown to be beneficial in small groups of patients. The Dutch have done large studies on these patients. They have a very large population there, and what they've shown over time is there's usually a gradual decrease in the severity and frequency of attacks and their symptoms. And overall, there's an extremely low risk of amyloidosis. Again, very different than FMF. We'll turn our attention now to the TRAPS. TRAPS is a really unique entity, and it's the most prevalent autosomal dominant fever syndrome. There's really no ethnic predilection. We can see it in any ethnicity. Although it was originally described in patients from Western Europe, we've now seen it in countries all over the world. Median age of onset is around 3, but we see adult onset cases very frequently. And again, there is a male predominance. The genetic abnormalities behind TRAPS has to do with the TNF receptor, as the name implies. And the gene is the TNF receptor superfamily 1A gene. And again, it encodes the TNF receptor that's on the cell surface. And there are a couple different mutations that can occur and cause problems with functionality. In a normal host, we have these proteases that, when activated, will cleave either free or bound receptor. And in doing so, the soluble TNF receptor acts as a scavenger, if you will, to control free levels of TNF-alpha in the blood. And when you have bound receptor, that protease is important to shut off the signal that's going to the cell to say, there's danger here. So what happens with TRAPS in some patients, not all, but in some patients, is that this protease isn't able to cleave the receptor properly. So now the signal is being continuously transmitted to the cell. A danger signal is being continuously transmitted. You can't send out soluble TNF receptor to act as a scavenger and control serum levels of TNF alpha. There's incomplete penetrance with these genetic mutations, and the chance of finding a mutation in a patient who has TRAPS-like symptoms is really dependent on the presence of an affected relative. So if you have an affected relative, the chance of finding a mutation are much, much higher. TRAPS patients have long episodes of fever, very long, and much longer than HIDS or FMF. These episodes of fever are associated with very intense myalgias. They have a lot of muscular pain, and it might be in a single limb, it might be in multiple limbs. Often this myalgia is associated with an overlying erythematous rash that actually travels, usually in a distal to proximal fashion. They have abdominal pain, just like the FMF and the hyper-IgD patients do. They can get conjunctivitis or periorbital edema. Pleuritis is a bit more common, and testicular pain can also be seen. So again, here's our figure looking at not only the calendar for the year, the timeline, but also the course of a typical attack. And you can see that it starts out here on day 1, and in this particular patient, they continue to have fever spikes almost out to day 22. They have very long episodes of fever. In this particular patient, they had conjunctivitis and erythematous, skin rash, myalgias and arthralgias, as well as abdominal pain. On the figure, the MRI here, these are stir images of a patient's upper leg. This is the femur here, and this is showing a pretty intense signal abnormality in the anterior muscle groups. And so what they did with this patient, this was at the NIH, they actually biopsied this area. And what they saw, this is an H&E stain of the patient's muscle, and it's pristine. It looks beautiful. So this inflammation that we're seeing here isn't in the muscle. This is a Mason's trichrome stain that looks that's looking for certain abnormalities within the connective tissue, and we can see that in this area here, there's an intense inflammatory infiltrate that signals a paniculitis. This is the fascia here, and again, you can see all of these inflammatory cells. So this patient both has a fasciitis and a paniculitis that's driving these MRI changes, and even though they're having muscle pain, there's no muscle inflammation. So again, treatment is, we can try nonsteroidals, which are fairly effective for fever control. We can use steroids, but we tend to need increasing doses of steroids. But luckily, we have a drug that works like our soluble TNF receptor that we were looking at on one of the earlier images, and that's called etanercept. So etanercept is an IgG molecule that has the ability to bind both bound TNF and unbound TNF in the body. And it does reduce the number of attacks, and it significantly reduces the total steroid dose patients are dependent upon. Again, the prognosis for most TRAPS patients is very good, and the amyloidosis rate is a little higher than the hyper-IgD patients at 25%, but not as high as the FMF patients. CAPS. CAPS is also very unique in that it's a condition that encompasses really 3 phenotypically different conditions, but is very similar in its genetics. And so we can see patients who have what's called familial cold autoinflammatory syndrome, Muckle-Wells syndrome, or neonatal onset multisystem inflammatory disorder as part of this larger group of CAPS. So the genetic abnormality is in this CIAS1 gene or the NLRP3 gene, and this encodes a protein that's called cryopyrin. This protein is expressed in white blood cells and as well as chondrocytes, and that's going to be important to remember here in a moment. But what's interesting is even though we see these three different phenotypes, the same genetic abnormality, the same genetic mutation can cause any one of the three phenotypes. So there is some modifier gene effect that we're still trying to determine. So again, this is a figure we've looked at before, and here's our caps. We have a mutant NLRP3 that actually drives formation of our active caspase-1 complex and forming IL-1 beta. If we think about this as a spectrum of conditions, and we go from the left here to the right, we're increasing in severity. This is our familial cold autoinflammatory syndrome. These patients get urticaria and fever when they're exposed to cold, and it can be just if they're outside on a summer day and they come into an air-conditioned room, they can have onset of hives and fever. It usually lasts for a very brief period of time, usually less than 24 hours. If we take the next step and we go to Muckle-Wells syndrome, these patients can also have their attacks triggered by cold, but not as frequently. They have recurrent attacks of fever, recurrent attacks of urticaria. They'll have joint pain and arthritis in association with their attacks. They may have eye inflammation like conjunctivitis, and they can be at risk for sensorineural hearing loss as well as amyloidosis, although the risk of amyloidosis in those patients is low. If we take the next step and we go to NOMID, the onset of the fever and the rash is usually within the first week of life, and they will get an intense urticarial rash and fever. They will have severe arthritis, severe eye inflammation, uveitis, optic neuritis. They're at a high risk for sensorineural hearing loss, and they can actually have chronic meningitis. This is a patient that was seen at the NIH and published back in 2002. They have some characteristic facies, although it's a little bit difficult to appreciate in this image, but they can have frontal bossing. They can have some saddle nose formation as well. And again, if you remember that cryopyrin is expressed in chondrocytes, and so when if you look at this patient's patellar abnormalities here, they get this bony overgrowth because of the overexpression, the inflammation that's going on in these areas of active growth. This is an image of the urticaria, but I think we've all seen urticaria in our offices. This is this lower image here is an example of the papilledema that they can get from increased intracranial pressure as a result of their chronic meningitis. This is a skin biopsy that shows a fairly intense leukocytic infiltrate in the dermal tissues, but really the epidermis is normal. And then this is an MRI, again, stir images that are that are exploring this patient's knees, and what we're seeing is that there's bony overgrowth on these patients, but there's no synovial enhancement. There's very minimal joint effusion. So this isn't arthritis, a classic arthritis. This is really a bony overgrowth issue. More examples of the bone overgrowth. Again, here's humerus here with the same thing, and again the urticarial rash. How do we treat these patients? Our usual suspects are involved. However, we rely very heavily on the IL-1 antagonists in this case. And these IL-1 antagonists have a light switch effect in CAPS patients, meaning with the first dose of the medication, the majority of these patients, their symptoms will go away. They're gone within 6 hours. Some patients are a bit more refractory. They will require multiple doses or higher dosing. But by and large, we can get patients under good control with the IL-1 receptor antagonist. This represents a significant step forward in our therapeutic armamentarium for CAPS patients. Every year, we're adding more conditions to these autoinflammatory syndromes. You may read about conditions like PAPA, which is pyogenic arthritis, pyoderma gangrenosum, and acne. There's a deficiency of the IL-1 receptor antagonist, which is a naturally produced protein that helps control the inflammatory response. And again, these patients get a pustular rash and they can get bone inflammation. There's Majeed syndrome, where patients get recurrent multifocal osteomyelitis, a neutrophilic dermatosis, and a dyserythropoietic anemia. Blough's syndrome in our differential of patients who have Crohn's disease, especially if there's a familial component, we should always think of Blough's. They can have a granulomatous arthritis, uveitis, and also have a familial colitis associated with that. The autoinflammatory conditions have been associated with increased risk of other rheumatologic conditions like vasculitis. So in patients who have an abnormality in their MEFV gene, they can have increased risk for HSP, polyarteritis nodosa, microscopic polyangiitis, or Behçet's. They've also found in conditions like multiple sclerosis that if you have certain polymorphisms in your MEFV gene, you might have more rapid progression of your multiple sclerosis symptoms. The same thing for Crohn's. If you have certain polymorphisms in your MEFV gene, you might be at an increased risk of stricture or extraintestinal manifestations for your Crohn's. R92Q mutations in the TNF receptor gene and other mutations have been found more frequently in patients who have lupus, rheumatoid arthritis, multiple sclerosis. And then, as I alluded to earlier, this condition called Blough's syndrome. Blough's is a result of a mutation in the NOD2 or what some refer to as a CARD15 gene, and this can be seen. The mutations in this gene can be seen more frequently in patients who have Crohn's as well. So, what's really fascinating about the autoinflammatory conditions and the defects that we've found in the innate immune system that are driving these symptoms is that it's giving us insight as to how the innate immune system also plays a role in the pathophysiology of more common public health conditions. And so if we look at atherosclerosis, we know that crystals that contain cholesterol can actually directly stimulate the inflammasome and actually cause an inflammatory response. Gout, same thing. Crystals can trigger activity in the inflammasome. Osteoarthritis, again, it's a crystalline stimulation. And then type 2 diabetes, high glucose levels, hyperglycemia, can actually stimulate the activity of the inflammasome and drive IL-1 production. And what's even more interesting is that people are now taking the next step and saying, well, what happens if we start to inhibit IL-1 activity in these patients? These are very early studies. A lot of them are animal studies. But there might be some benefit. Now, I think any talk about the autoinflammatory syndromes, hereditary fever syndromes, really, especially for a group like this, wouldn't be complete unless we talked about PFAPA or periodic fever, aphthostomatitis, pharyngitis, and adenitis. This is not yet classically included in the autoinflammatory syndromes because we really haven't found a genetic abnormality at this point. It's probably there. We just don't know where to look yet. However, it is far and away in the United States the most common cause of periodic fevers. Again, that term periodic fevers is key. The onset is in early childhood, somewhere usually between ages 2 and 3, but certainly less than 5. There's a male predominance. There's a familial predisposition. Up to 45% of patients who have PFAPA will have an affected first-degree relative. And as of yet, the etiology underlying PFAPA is unknown. So with PFAPA, these are predictable episodes of fevers lasting 4 to 5 days that occur about every 4 weeks. And these, again, the key here is that they're predictable. A family member will be able to come and tell you, I know that my daughter is going to have an attack next week. And usually they're right. When you hear that, there's only 2 conditions that you should think of. You should think of PFAPA, as long as you haven't been to Africa and you don't have malaria. But you should think of PFAPA and you should think of cyclic neutropenia. That's it. So if you have somebody who says every 4 weeks or every 5 weeks, my child gets a fever, I can guarantee it. That's it. There's your differential. 2 things. It's such a simple question to ask when we're thinking about recurrent fevers. These patients that have PFAPA, their fevers will last 4 to 5 days, and it's usually associated with one of the following: cervical adenopathy, pharyngitis, oral aphthay, so oral ulcers, abdominal pain. They can also have headaches and myalgias and arthralgias. The top 4 are the ones that we see most consistently. Abdominal pain occurs almost as frequently as the oral aphthay, okay? And sometimes those aphthous ulcers can be tough to see. They can be in the posterior pharynx, and so you really have to get a good oral pharyngeal exam on those kids, and you have to see them at the time of their fever. It's critical. See them at the time of their fever. Do a great head and neck exam. That's really, that's really all you need for PFAPA, and a majority of the time you're going to make the diagnosis. How do we treat these patients? Systemic steroids, so 1 or 2 doses of oral prednisone or prednisolone within about 6 hours, 12 hours of the onset of the attack is very effective. It completely stops the attack in 90% of patients. The drawback is that in up to 50% of patients, they can have an increased frequency of their fevers. And that 50% number actually comes from our population here that we've tracked very closely. Half the kids that we give steroids to develop more frequent fevers. Other centers, they have about 20 or 30%. We're not really doing anything different here that's being done anywhere else, but our numbers are 50%. We can use cimetidine. Cimetidine has an effect on T cells, and we can use colchicine, and those can be effective in preventing attacks in up to 30% of patients. Tonsillectomy. We don't know why, but tonsillectomy is almost curative. And so for patients who've had an increased frequency of attacks due to the steroids, or if we feel like we're needing to use the steroids too frequently, we'll refer them to our ENT physicians for a tonsillectomy. And within 6 months, more than 90% of patients have had a complete resolution of their symptoms. Gone. They don't come back. Overall, the prognosis is very good. Usually within a 5-year period, patients have had a reduction in the severity and the frequency of their attacks. And so most often, because of this fairly good prognosis without us doing anything, we won't treat patients unless it's really affecting the families. So some families, every time their child gets a fever, they can't go to daycare, and so the parent has to miss work, and it's very stressful for the family. Or every time they get a fever, they see their provider, and the provider gives them antibiotics, and the family, and we get into this whole cycle. And so oftentimes, we'll talk about treatments. We don't automatically treat patients, but if there's a significant impact on either the patient's or the family's quality of life, then we'll initiate therapy. This is a little flow chart that I have been using to guide our evaluation of patients who have recurrent fevers. And again, when we talk about recurrent fevers, I'm gonna just assume that you've done your homework and you've ruled out any infectious or oncologic possibility. Okay, so once you've gone through that and eliminated the usual suspects, how do you think about these patients? So if they have fevers that last for 3 days and they have serositis and they're of Mediterranean descent, you should think about FMF. Okay, and you could send the MEFV gene for an analysis, and you can consider a trial of colchicine. Longer episodes of fever with periorbital edema, conjunctivitis, or migratory rash, then we're going to think about TRAPS, and we would think about using twice weekly etanercept in that scenario. If they have cold-induced urticaria, sensorineural hearing loss, or other CNS symptoms, we think about Muckle-Wells, the cryopyrin-associated syndromes. Prominent lymphadenopathy, rash on the palms and soles, attacks triggered by vaccinations. Again, that key, attacks triggered by vaccinations. We think about hyper-IgD syndrome. Neonatal onset with an urticaria or rash, and they have bony overgrowth. We think about NOMID. And then PFAPA at the very end. Now, if they don't meet any of those things, and they have rash, they have eye inflammation, they have an atypical arthritis, osteomyelitis, colitis, then we might think about the more rare autoinflammatory conditions like Blau's syndrome or Majeed's. I think if you take a patient through this pathway after eliminating those infectious and oncologic etiologies, then most of the time you're going to make the right diagnosis. So in summary, the autoinflammatory conditions are the result of disordered regulation of the innate immune system that leads to increased production of IL-1. There are genetic polymorphisms in genes that regulate the inflammatory response, and this contributes to the pathophysiology of more common conditions like atherosclerosis, type 2 diabetes. The diagnosis of the autoinflammatory syndromes is largely based on history and response to therapy. So one thing that's important to remember is even though these are all genetically mediated, only about 70% of the patients who phenotypically fit one category will have a genetic abnormality. So if, for a condition like FMF, we see a large number of patients who look like they have FMF, but they might only have one gene that's abnormal or no genes. But yet they still phenotypically look like they have FMF, and we treat them just the same. So we're still in the very early stages of understanding the genetics behind these conditions. The treatment of the autoinflammatory syndromes is largely aimed at controlling the pro-inflammatory cytokines like IL-1 and TNF. Okay, that's it. If anybody has any questions, I can pause here.